And in terms of the clinical challenges patients face when diagnosed with an AKA event post-procedure, can you speak a little bit to certain patient outcomes or and/or healthcare associated cost?
And I think we've made a lot of progress in understanding the impact of AKI. If it's simply a change in the serum creatinine, then people may not be moved by that, right? It's just a number changing, so what? But when that number changes and the needle moves the patient closer to dialysis, when that number changes and it prevents the patient from getting other procedures that they might need, more interventions, for instance, or at baseline having bad renal function dissuades providers or patients or their families from pursuing medical treatment. That's important. And then when you actually do have the event, we know there's an association now with bleeding, with myocardial infarction, and as we mentioned earlier, readmissions.
And are there any society guidelines that provide direction on how to prevent contrast-induced AKI in the cath lab?
Going to the societal guidelines, I would say the societal guidelines have been playing a little bit of catch up. They've spoken to discrete elements that are helpful, things like minimizing nephrotoxins, maintaining euvolemic volume status and administration of volume, limiting the total volume of contrast dye that's used. Certainly, those things are the key. Those are the fundamentals. But I think we've really advanced over the last decade. We're more in tune with contrast limits. We understand that as little as twice, the patient's EGFR, that's 2 times EGFR is a great ratio to know. It's a great relationship of contrast limits. So we know that even for modest amounts of contrast that we think are not that important, you can have an impact on kidney injury.
And what approach and/or technologies do you use to prevent AKI during diagnostic and PCI procedures?
So, I'm proud to say we do have one of the lowest AKI rates in our region, despite having a very sick population of patients. And the way we've approached that is one, through education, so teaching nurses, physicians, the hospital administration about the importance of AKI prevention. We've really made that a focus. So we screen patients appropriately, set contrast limits, include not just the creatinine level, but the EGFR in our board rounds. When we talk about patients, we use a very conservative contrast limit threshold. We incorporate dye saving technologies. So we use Divert to not only monitor our contrast use in real time, but we also reduce contrast delivery. We are mindful even during things like TAVR procedures and peripherals to monitor our contrast use and limit contrast delivery. We use isoosmolar contrast for at-risk patients and cases where we know we'll have a large amount of contrast volume used. We stage procedures. So if we've already given a large amount of contrast dye, we stage the subsequent interventions. And then we have a close working relationship with nephrology. So we have no problems emailing, calling, discussing our cases with nephrology.
Technology and interdisciplinary discussions are essential to managing these patients and making sure that we can provide them with the best possible outcomes. And lastly, so as we discussed before, you're the co-founder of the largest cardiorenal conference. Can you share a little bit about why you've started the conference?
Yeah, so when you look at the medical conferences out there, there's so many kidney conferences, heart disease conferences, but what I felt was an orphaned area was really the strong interaction between the heart, the kidney, and underlying that the metabolic systems. No one likes taking care of these patients because they're so challenging, so they often don't get the appropriate care they need. They don't get multidisciplinary care, And oftentimes the cardiologists are too scared of them, the nephrologists are too scared, the primary care is too scared. So working with Dr. Bunsell, my co-partner in the Cardiorenal Connections, we said, let's break down those barriers. Let's bring these people together and start talking about the kidney and the heart, not as separate entities, but as interrelated organ systems. And understanding that the metabolic syndrome and diabetes underlies both organ systems. So we had a great response, great turnout. The meeting has grown every year. And, it's frankly probably the largest heart kidney symposium that's held worldwide now. And, we're about to launch our 5th annual session. It'll be all virtual in January. The end of January, we'll have 3 days, the 27th, 28th, 29th, of poster session, scientific session, international speakers, and plenary and concurrent sessions covering a variety of different topics. As I mentioned earlier, we're going to delve into kidney cancer and cardio-oncology this year. We'll have a strong focus on health disparities again this year, practicing medicine in the pandemic. We're going to talk about telemedicine and smart technologies to treat patients with kidney disease and heart disease. We'll also have a recurrent focus area on complex cardiovascular procedures, AKI prevention, picking the right tools. An exciting area is calcium. So we're going to have a whole summit on calcification. Underlying heart kidney disease, and one of the reasons why we often end up using a lot of contrast dye is we're dealing with calcium, vascular calcium, vessel calcium, valvular calcium, and treating calcium is associated with worse outcomes, complications, and requires more contrast dye. So we're going to really dive into why patients with kidney disease get calcium, why vascular calcium is important to understand how to treat it. So I'm really excited about that whole calcium summit that's part of Cardiorenal Connections.